Hello, this is Wendy Wood, and we're going to be talking about impaired aerobic capacity and endurance. And I want to begin emphasizing how important aerobic capacity is, even for functional ADLs. So this is going to be very important for you to assess. There are a number of influencing factors: deconditioning. So when someone is deconditioned, their aerobic capacity is going to go down naturally. Also, with age-related physiologic changes, we see decreased cardiac performance along with decreased skeletal muscle, and this is going to lead to reduced max oxygen consumption. Many different pathologies can be associated with decreased aerobic capacity, and this is a very short list. There are many others: stroke, Parkinson's disease, OA or osteoarthritis, bone fractures, cardiovascular disease, pulmonary and metabolic changes or metabolic pathologies also. And there are many different reasons for this. So with OA, for instance, the person may have pain, so the individual is probably doing less, and that leads to decreased strength and decreased activity, which leads to decreased aerobic capacity. The good news is there is an upward spiral, but the downward spiral is seen when aerobic capacity is associated with decreased functional mobility, disability, and loss of independence. And of course, it goes both ways, because once somebody starts doing less, the muscles get weaker, the aerobic capacity is going to go down. However, the good news is even when there is disease, physical activity is associated with postponed disability and independent living. The benefits of exercise cannot be overstated. And your book really does emphasize that, but we know exercise is very, very powerful. In terms of the exercise effects, Table 12.1 in your book goes through a nice list of many different things that improve. Submaximal and maximal oxygen intake, when those improve, this is strongly predictive of functional mobility improvement, whether or not the person has impairments. In one study by Blair et al., it was found that the level of aerobic fitness was inversely associated with the risk of cardiovascular disease. So when aerobic fitness went down, cardiovascular problems would go up. Strong evidence of many health benefits of regular physical activity. So all of these things can be lowered. The risk of early death, risk of coronary coronary heart disease, the risk of stroke, the risk of high blood pressure, the risk of type 2 diabetes, metabolic syndrome, colon cancer, breast cancer. Weight can be lost and the person can improve their cardiorespiratory fitness. Aerobic activity can help prevent falls, decrease depression, and even improve cognitive function. And this is all by the U.S. Department of Health and Human Services from 2008. And it goes on to list the things that would be moderate to strong evidence. So there's a number of those: better functional health, reduced abdominal obesity, lower risk of hip fracture, lower risk of lung cancer, lower risk of endometrial cancer, weight maintenance, improved bone density, and improved sleep quality. So many different things. Even in the presence of diseases like COPD, CHF, peripheral artery disease, and stroke, exercise is beneficial. Again, cognitive function can be improved, flexibility and speed, motion function, even auditory and visual attention. I wanted to cover some of the terminology associated with the physiology of aerobic capacity. So aerobic capacity basically is the body's ability to take up, deliver, and utilize oxygen. VO2 is a physiological measure of how much oxygen the body uses at rest or during activity. And VO2 is cardiac output times arteriovenous oxygen difference. So we can break that down further. Cardiac output is stroke volume times heart rate, and arteriovenous oxygen difference is arterial oxygen content, and you're going to subtract the venous oxygen content from that value. So that's actually an equation. Okay, I wanted to discuss heart rate. Heart rate is related to oxygen consumption. So there's a linear relationship. So as heart rate increases linearly, you'll see oxygen consumption increasing also. There are age-related decreases in max heart rate. So estimated max heart rate is 220 minus age. There's some other different formulas also. So it's obvious the older you get, the lower your max heart rate is going to be. What's important, and this is on the bottom, is aerobic exercise leads to a decreased resting heart rate. So if the resting heart rate is decreased, then the person can actually have more leeway. So for instance, if someone decreases their heart rate from resting heart rate from 80 to 60, and that person is, say, 40 years old, that means their max heart rate is 180 beats per minute. So that gives them more leeway, 120 more beats per minute, so they can do more activity when the resting heart rate decreases. Another important influence with heart rate is the autonomic nervous system. Influences heart rate. Now with age, and especially some diseases that occur later in life, like diabetes, heart transplant, stroke, and heart blocks, autonomic dysfunction is disrupted, so that can lead to problems with heart rate. Cardiac output at rest is normally about 5 liters per minute, but that can increase to 20 to 40 liters per minute. With age, though, cardiac output goes down. And the reason why that is there's decreases in heart rate and stroke volume. Exercise training, though, can result in an improvement with cardiac output. Let's go now to the physical therapy exam, and we're going to talk about all of these elements: the history, intake and screening, the systems review, tests and measures, including graded exercise testing. Self-report measures are important. And then we're going to go into evaluation, diagnosis, prognosis, and plan of care. So let's begin with the history and important screening questions. Signs and symptoms that would be important to look at. Shortness of breath at rest or with mild or minimal exertion is very important. Angina, so that could be pain in the chest or the jaw or the left arm. Orthopnea, so basically what that means is the person is short of breath when they're lying flat, so they tend to prop themselves up with pillows. Tachycardia, paroxysmal nocturnal dyspnea, oops, sorry about the typo there. Bilateral ankle edema, so generally that's going to be signifying possible congestive heart failure. Palpitations, leg claudication or leg pain with walking, and exhaustion with just usual activities. Screening for cardiovascular risk factors is very important. Your text has a nice table, 12.1. So even some basic things like age, men 45 years or older and women 55 years or older. Of course, if someone has a family history, cigarette smoking, sedentary lifestyle, obesity or body mass index greater than 30, or waist girth more than 40 inches for men, more than 35 inches for women. And this is in your book, page 235, hypertension, dyslipidemia, or problems with lipids, prediabetes, and also high serum HDL cholesterol. So these factors are very important to determine. Remember, cardiovascular disease is number one reason for mortality in the older adult. In terms of screening of systems, the integumentary, musculoskeletal, and neuromuscular systems are very important. You do want to assess the heart rate, the respiratory rate, blood pressure, and you want to check for any edema, especially bilateral edema, pitting edema. In terms of test and measures, the 2 or 6 minute walk test are very important. You want to get a baseline measurement, and you also want to look at improvement after therapy. You definitely want to get heart rate and blood pressure before they begin walking to make sure they're appropriate for the test. Other measures, very important self-report measures. So the SF-36, or the short form 36 health survey, and other disease-specific self-report measures. So there's a ton of those. There is the Minnesota Living with Heart Failure questionnaire and the Kansas City Cardiomyopathy questionnaire, many different ones. You can also look at disease-specific measures, related to, like, say, Parkinson's disease, many different things. You do want to consider when you may need to refer a patient out. You should definitely be aware of aerobic activity contraindications. So some of the absolute exercise contraindications would be unstable angina, uncontrolled dysrhythmias, uncontrolled symptomatic heart failure, an acute cardiac event, acute systemic infection, or a recent change in ECG reflecting possible cardiac dysfunction. So you should also be aware of reasons to stop exercise. In terms of interventions, therapeutic exercise, functional training, assistive device prescription, those are all very important. Again, assistive device is if needed. The person may not necessarily need them, but if the person's balance is impaired and an assistive device does improve their balance, then they may actually be able to do more activity. Airway clearance, if needed, that would be for somebody with mucus. So those are some other specialized techniques. In terms of exercise prescription, the 4 main components of an exercise program are the mode, intensity, duration, and frequency. Mode really can be variable. Of course, you want to pay attention to safety, but there's many different things that you can do. Intensity, 16 to 90% of max heart rate, or if you're using a rating of perceived exertion scale, an RPE scale, if you have a 10-point scale, 4 to 6, or a 19-point scale, 12 to 16. A duration of 20 to 60 minutes of continuous activity. Frequency would be on most days. The new guidelines are 150 minutes a week of moderate intensity exercise or 75 minutes of vigorous intensity exercise. Of course, if you have somebody that's at risk, somebody with congestive heart failure, you're probably going to do shorter bouts of exercise, but more of them. So you want to be monitoring the vital signs. Okay, so these are things that you're going to pay attention to when doing the intervention plan for your patient. Whatever your patient's diagnosis, you can almost bet there's going to be a component that relates to aerobic activity, aerobic capacity. Thank you very much.